This podcast is in partnership with Astellas Pharma.
Hey everybody, I'm your four-eyed professor, Chris Lievens, and I'm super excited to talk to you today. Our roll call is for new and experienced ODs, optometry students, and even those just interested in this profession. We'll cover a number of topics together, and I'll help you see them through a professor's eyes. Please take your seats. School's in session. Welcome back to the podcast, everybody. I appreciate you attending again, and we are going to continue on with the theme that we started really last year, and then recently as well, to spread the word about some of the critical issues that surround us as practitioners and patients in their eyes with regards to geographic atrophy. This content, today's podcast, we're going to kind of frame this around protecting vision and really trying to lean into the timing of bringing this up for discussion, bringing this up for referral, bringing this up to patients at the right time that we can actually potentially, anyway, have the most impact on protecting their vision. I hope you're as excited as I am that I'm going to bring to the stage a guest that we've had on the pod a number of times. It's Dr. Jessica Haynes. So, Jessica, thank you again for joining the Four-Eyed Professor podcast and me, Chris Lievens.
Thank you, Chris. I appreciate you having me on again. And I'm excited to talk about this. I know we've had these meds out for a little while now, but I think there's still a lot to discuss and a lot we've learned over the last 2 years.
Yeah, no doubt. So before we get going and before we dive in, your role in eye care is unique. Certainly unique from probably most of the people, if not all, listening. So bring us all up to speed on what is your day to day.
So it is a little unique. I work specifically in a retina specialty clinic. So we are on the ground, working with patients who have GA, patients who have retina only problems, and very focused in that realm. And it is a little different because we talk in this and certain articles we write and whatnot about, what is the referral process like when you have a person you're sending out to a retina specialist who has GA. And it's a little different for me because I'm at the clinic that gets referred to. So it's sort of a unique situation there, but it's interesting because I get to actively walk the patients through the treatment options. I get to walk them through their disease, and we kind of make those decisions together whether they're going to pursue treatment or not. Even though we're not actively doing the treatments, we get to make those conversations or make those decisions with our patients.
I love it. That's exactly why you're on the podcast today, because this is totally in your wheelhouse. So let's just start off at the beginning. So when you identify, let's say, in your own independent patient that maybe was referred to you, or maybe there was referred to for a suspicion of something, but that something wasn't delineated. But in your visual observation of the patient, you identify some signs of geographic atrophy. How do you bring that up to the patient? What context do you use? Is this a topic or a name that's familiar to them, or is it totally not?
That's a really good question. A lot of people they're not familiar with geographic atrophy. Many still are not. But you would be surprised how many people are aware of the phrase because of the campaigns,
Oh, sure.
the patient advertisements. People do see this on TV, they hear about it on the radio. Maybe they don't remember that name specifically, but I do think when you bring it up to them and they hear about it, they're like, "Oh, yes, that's what I have." So I do, a lot of times we like to use common phrases like you have a blind spot in your vision or you have a degeneration or something like that. But I do think it's becoming more important to tell the patient the specific name of what they have, geographic atrophy, because they may hear that again and it sort of emphasizes to them what this is. This is a legitimate treatment. There are other people that have this. But that first visit, it's kind of a doozy. You never know how much information the patient has about macular degeneration, period, Some of them have never even been diagnosed with macular degeneration of any stage, and now you're telling them they have the end stage or the most advanced stage of dry AMD. So there's a lot of work that has to be done on the back end, I do think, to be successful moving forward. And that goes through talking to them about what the disease is itself, what geographic atrophy is. It involves going through all of the things that you can do, even lifestyle modifications and whatnot, to try to slow it down. And then talking about the specific treatments for geographic atrophy. So, most patients, I would say, even those referred specifically for GA who know they have GA or have been told they have it, most don't embark on treatment on the first visit because that's a tremendous amount of information to
Sure.
digest. So they kind of go home. We give them some information to take with them. There are some patient specific websites they can go to kind of learn more and let them mull over that for a couple of months to come back and ask more questions. And sometimes we do that 2 or 3 times before a patient decides to ultimately embark on treatment.
So I would guess that a lot of patients are familiar with the concept that in a number of diseases, a number of systemic diseases, the body does some aberrant things to attack itself unusually, and that causes some major issues. You know, is that the framework that you put for geographic atrophy, or do you phrase it differently?
So that's a really good, concept. I like that, Chris. I actually don't really talk about the body attacking itself, but you're right. I mean, we have an immune system that's overactive.
Right.
I sort of honestly describe it as this is almost like an aging process that's happening too fast. The inside of your eye is degenerating, it's atrophying away, and you're getting these almost like bald patches of retina that are losing sight over time. I don't get too into details about even with the complement inhibitors. I don't even really talk to them about what this is actively inhibiting. And I've never had a patient that's asked, which is kind of funny to think about.
I think the only reason that I started going in that direction was the volume of cancers, for example, that are caused by inflammation at its most basic level. And when you give a patient an example of something that sounds really complex, but it ends up being, though it's still complex, you can break it down in this simplistic fashion. It still sounds unusual that these things can occur in life, but they really can. So let's pivot now to what I'm seeing, no pun intended, in
Mhm.
with my colleagues at large, and I see some that are very adept to early identifying and intervening with action right away. And yet I also see an alarming group that identify, which is great, but take almost a wait and see approach, and then a referral gets stalled. Uh, and then, like you alluded to, you end up having a conversation with the patient much later for end stage issues than what's optimal, which is early intervention.
Oh, yeah, I think some of that is a lack of comfort in managing a condition that we haven't had a treatment for in the past. Anything that's new, it does take a little bit of time for yourself to become confident in the conversations you're having with patients and really confident in the referral. And if you don't have a confidence in what you're doing, you don't feel really compelled that this is the right treatment for a patient, you tend to have this tendency to, well, this is here, but it's not that bad. Let's just wait and see what happens. And you have a bias for that. And then when the patient comes back, even if it's gotten a little worse, you kind of have this bias. Well, it got a little worse, but it didn't get that much worse. And you do that for a while. And if you're seeing a person every 3 or 4 months, maybe there's not a lot of change, but you look back over a year or you look back over 2 years. And if you take away that bias of, we have been told for so long that this is a slow moving, slowly progressive disease. If you take that away and you really sit down, you're like, wow, that's gotten a lot worse in a year, or that's gotten a lot worse in 2 years. So I do think there's, a little bit of lack of comfortability in talking about it. And then there's this very long-standing bias that we haven't had a treatment for it in the past. And so we're kind of inclined to tell patients, yes, you have this, but it moves slow. Because what else are you going to tell them? There was nothing else you could do for this in the
True.
past.
Yeah, great point. And so you really articulated very well what has brought us to where we are now. So how might you suggest that we shift mindsets and say that detection should lead to action?
That's a good question. You know, a big thing is like the proof is in the pudding or whatever. Look at these patients and see what has happened to your patients if you've had them in the past. Look at the natural history of this and take out that bias of this slow moving disease and just observe. If you've had a person you've been watching for a couple years, see what a significant progression there can be in that short period of time. And then we also kind of have a bias too that patients don't do well with injections. Patients are fearful of injections. Injections are painful. Start talking to your patients who've had intravitreal injections, or if you refer a patient for GA, bring them back and have a conversation about, how are your treatments going? Most of these patients honestly do quite well with treatment, and a lot of patients are really familiar with intravitreal injections now, especially in that age group. A lot of them have friends who have been getting injections for exudative AMD for years now. And as you sort of get that experience yourself, because Chris, you and I can sit here and talk about this all day long, but until you sit face to face with somebody, or you really sit face to face and you look at a person getting worse and worse year after year, it's hard to, it's hard to be uh, it is hard to be aggressive with the treatment.
It's funny you mentioned that, Jessica, because I do that every single time I see a patient that's on a regular course of some type of uh, intravitreal injections. I ask them, "So, when did it start? How's it going? What's your experience?" And you're right, this just becomes part of their lives. It's definitely not scary anymore because they've been in it and doing it, and it's really much a matter of fact. This is what they're doing to maintain vision in a
Mhm,
lot of cases. And so in that vein, uh, when talking to patients with regards to treatments like products that are like Izervay that's on the market right now, how do you describe that? Well, probably number one, and in most cases, we're not bringing back lost vision that you've lost, and we're not just trying to necessarily slow a disease state like we do with other interventions, but we're really trying to maintain what they have and protect the vision that they still have. Is that what you say, or do you do something a little bit different?
So, I think you have to phrase it in a way that both brings about the reality of the situation to the
Mhm.
patient, but gives them hope in what they're doing. Because if you do phrase it as you're going to get shots every month, you're going to get worse still, you're still going to go blind eventually, why would I do a treatment like that?
Yeah,
I mean,
totally.
why would I do something like that? But the reality of the situation is it is a treatment that is ongoing, indefinite. Every month, every other month, you have to get a treatment, that does require an injection of medicine into the eye. It is very important for patients to understand that it does not make them see better. That's really crucial, and sometimes that honestly takes a few, treatment cycles to really kinda set in even though you say it from the beginning. Because if the patient doesn't understand that, they're gonna be very dissatisfied with what they're doing, and they're gonna be less likely to continue on with treatment. So they do have to understand that, but also telling them that by doing this, you are being as proactive as you can to keep the vision that you currently have. We cannot make you see better from here, and unfortunately, the disease tends to worsen even with treatment. But if you do this, you are literally being as proactive as you can to keep the sight that you have for longer. And I think that that is somewhat empowering for patients to know that I'm not just waiting around to lose my vision. There is a treatment option. I'm being proactive to pursue it.
I really do like that. Sometimes when I have a patient that appears to be, well, scared, which I totally get, but also a little reluctant, um, I share with them that what we have today, we didn't have recently. And what we have today, previously, we really had nothing. And so the fact that we have something, though it may not treat 100% of patients, it's still a significant percentage. And what I don't want from the patient sitting in front of me is for them to stall and not make the leap into treatment. And then the next medical scientific advances for a brand new intervention does much better for patients who were already on something like Izervay. And now it's going to make them better. But now, because we've stalled for many reasons, that patient may be left in the lurch. And I don't want any of my patients there. So that's not based on science. That's not based on something that I know might happen, but it's something that I've seen happen in other disease states. And so to me, if we can get patients to accept, which some, like you said, sometimes may take a few visits and a few discussions, uh, but get them going in the right direction, there's only a better chance. If you leave them where they are, well, we know what's going to probably happen for them.
And, you mentioned something about fear. I think that's so important. If you have a patient who hears this treatment option, and we all understand, like you said, we all understand that this is not the treatment we all hope to have for GA. We had nothing. Now we have this treatment option. It is certainly better than what we had. Ideally, you would give a patient a single eye drop and cure them and reverse, and they would see 20 vision like they did when they were 21 years old. Obviously, there's a lot of, downsides to the treatment, the fact that it's ongoing, the fact that it requires an intravitreal injection, and the fact that it has, potential side effects and it doesn't reverse. But still, still it's a valuable treatment option. And if a patient hears the pros and cons of treatment
Mhm.
and they sit down and they say, I understand what I have. I understand what can happen. I do not want to pursue treatment. This is not what I want to spend my current time. This doesn't align with my current values for my life in this at this time in life. I think that that is absolutely acceptable. But I don't want patients, and I even tell them this, I don't want you not to pursue it out of a place of fear, fear of injections, fear of whatever that fear may be, fear of having to come into the office too many times, fear that it might be uncomfortable. If they choose to do it because that's what they feel is best for them, certainly that's something to respect. But I don't want them not to do it out of a place of being afraid.
Yeah, that's a really good point. So, Jessica, is there a ideal, optimal, critical window for intervening with a treatment such as Izervay to have its greatest potential impact and effect? And are there risks if we wait too long from the ECP perspective to make the referral to retina? And then obviously have these conversations with the patient, decide to opt in, opt out. And if they opt in, well, now more time has elapsed. Is there a window in your mind that's the prime time to intervene, and what might that be?
There are certainly patients who are more ideal candidates for treatment than other patients. And even as we are so much more observant of GA and dry AMD at this point, there are sort of different characteristics per patient of how it tends to progress or evolve. So you do have some of these patients who have these localized drusenoid PEDs that kind of collapse. They'll get like very quickly this localized area of atrophy that may not move as fast. Those patients are probably less ideal candidates for the benefit of it than someone who has an extrafoveal lesion that's, been slowly kind of growing and engulfing the fovea. So you do have these patients that potentially would benefit more, the patients that would potentially benefit less. But if you have a patient and they seem like a good candidate for this, and they'll ask, well, when is the right time to start this treatment?
Right.
The right time to start the treatment would have been probably like 10 years ago or so.
I know.
So, we have this system that has been faulty, and if this is due to your genetic makeup, it's been faulty literally your entire life. The ideal time to stop it would have been at the beginning. Of course, that's not possible. So when is the next ideal time to start inhibiting is now. And the longer you wait, the more tissue you lose. And, the studies continue to show that the longer patients are on treatment, the further those, sort of slopes diverge as far as your treatment arm and your non-treatment arm, that the longer you're on it, you have a greater decrease in the progression of the disease.
Yeah. I'm going to ask you again a question that we kind of already covered, but I want to frame it just a little bit differently because there's a lot of human issues here on both the ECP perspective as well as the patient perspective. That's incredibly common, and so it's the patient who says, "Oh wow, I have a spot on my arm, but it's probably nothing. And it's probably going to go away." And maybe it's fall coming into winter. I'm going to wear long sleeves. I'm not even going to look for a while. And I guess if it's like a pimple or a mosquito bite, maybe it does go away. But a lot of times those spots do not go away. And on the ECP perspective, it's, ooh, that looks a little peculiar. I hope that that doesn't get worse, and I hope that that goes away. And this kind of creates this denial perspective from both the provider and the patient, this wait and see habit, which in situations like the condition we're talking about is problematic. So, because that causes a referral delay, it's becomes cultural, becomes habit, the wait and see habit. So, can you think of any steps that we can take today and break this wait and see habit on behalf of both the ECP and the patient to make the most timely referrals that we possibly can?
From the ECP standpoint, the more comfortable you feel in making a diagnosis, like the more comfortable you feel in reading the OCT and feeling confident that you have a patient with AMD and they're not just, early AMD and they're not just intermediate AMD, they have advanced non-exudative AMD, they have GA, or even this is a person who's intermediate that I'm particularly worried about. I think has some high risk characteristics that they'll develop GA. The more confident you feel in that, the more confident you're going to feel in making a referral because our fear, I do think some ways we're always afraid we're going to inconvenience people. We're afraid we're going
Yeah.
to inconvenience the patient. They're going to have to drive all this way. We have some sort of weird fear that we're going to inconvenience like the retina specialist, that they're going to have to see a person that doesn't need treatment or doesn't have, enough GA. Um, One thing I tell people when they say, should I refer this or not? I'm like, well, if you don't feel comfortable in making the decision on what to do with it, or you think the patient needs an intervention that you can't provide, you have to refer it. And I mean, we get paid to see patients, so I'm not going to be mad that you referred someone to me with a teensy spot of GA. We talked about it. We ultimately decided not to treat it, but at least we've started that conversation. We've started that process because, again, it can take some time to get a feel for the patient to get a feel of the situation and decide to embark on treatment. That doesn't all happen at once. And interestingly, this is a different situation, but I had a diabetic patient recently who was talking to me about how they did so much better with their blood sugar control when they finally saw an endocrinologist. And they thought, some of this was from the
Mm,
expertise of the endocrinologist. But she also told me, I had never thought about this before, that when she saw the endocrinologist, in her mind, she's like, this is so significant. I need to see a specialist. This is something I need to pay more attention to. So before she was going along, she was just seeing her primary care. She thought, I don't need to worry too much about it. When they said, I think you need to see an endocrinologist, she took it so much more seriously. And so, if you have a patient who has AMD, and you're seeing them every 4 months, like, "Oh, you're fine, just come in another 4." They may not take that very seriously, or they just think they have a little AMD or a little something going on. If it's significant enough to see a specialist, maybe, maybe not, but maybe that makes them take their situation slightly more seriously. And again, you have to take out this fear that, well, so what if the patient drives a couple hours and they don't feel like it was useful for them? You're doing what you think is best for that person, you know? So,
I really like that because I hadn't thought about that either, but that makes perfect sense. That when we make the extra step to send the patient to another level of care, the implication is it's worse than it ought to be, and
mhm.
it requires greater intervention. So
Yep.
I'm going to ask you a question, and then mainly because I've known you for so long, Jessica, and I can't count how many times I've asked your opinion on patients that I'm seeing. But I think that this is really in some mindsets of ECPs, and that is if we send you a patient and we got the wrong diagnosis,
Mhm.
whether it's worse than this or less than this, we're just off. Are you going to think ill of us? Are you going to make us feel bad? Are you going to embarrass us because we got something wrong?
You know, this is what we're here for. If someone else knew everything that we know, they wouldn't need me anymore. I would have to, I guess I just have to go home and hang out. But no, and also, all understanding there are so many aspects of eye care that I don't have a clue about. I haven't fit a contact lens in maybe like 7 years. I don't know what contact lenses are available. There's so many things that I'm not in tune with. I don't expect everybody to have the same level of, understanding of the retina because that's what we do all the time. So you shouldn't have that fear either that what if I send it and it's the wrong diagnosis? What if I send it and they say something different? And I really wish that any person that made you feel like that, you didn't have to refer to them anymore. I do also understand some people are in situations where that's the only what is it called? The only pony in town or something like what is the phrase? That's the only option they have, but I really wish if someone made patients feel that way or made referring doctors feel that way that they had the option never to send that person there again because, that is what you're there for is to make those decisions and make those diagnoses. We can't expect that everyone has the same equipment in their offices that we have or has the same level of knowledge of retina care that we have.
Yeah. You know, part of the challenge I think is when I mentally compare posterior segment eye issues versus anterior seg eye issues, a lot of things in the anterior segment um, can be with an intervention can go away and be fixed. There are some in the posterior seg as well. However, there's a lot where the mental switch has to be more about protecting and maintaining than really reversing and getting everything to go back to the way they were. And I think that that creates an intimidation factor that really that ought not be there. But I think if we can get completely the MD collaboration in the and embrace protection and not just go after fixes, it potentially can improve patient outcomes.
Oh, I agree. I mean, especially in the retina space, there is a tendency like something is broken and I want to fix it. You have DME, we're going to treat it, it's going to get better. Or even if your vision doesn't get better, it's going to physically look better. On the OCT, I will have a metric to show someone improvement. You
True.
have a CMV, we're going to make it look better on the OCT. If you're detached, we're going to reattach your retina. So there really is this tendency to see something and want to fix it. And that is difficult when managing GA because you aren't fixing it. And that's why I think it's so important to have a really solid conversation with your patient so that you're all on board and you all understand these treatments and their risk and their benefits and the help that they can have. Um, but also from the OD community, knowing that, a lot of retina specialists are seeing high volume of patients. They don't have a significant amount of time to have these one-on-one conversations. And so your role can be extremely helpful to patients when they're making these decisions. And that's hard because in a way, maybe it shouldn't have to be. Maybe you should be able to refer to the specialist and they just take care of the situation entirely. But if you do have a really good understanding of it, if you've got a really good understanding of diagnostic imaging and AMD, and you can be helpful in starting that conversation. The patient has their visit, they come back, they still have questions. You can kind of be like helpful in answering some of those questions. I think that can really change a person's outcome too, because it can be just entirely overwhelming to go to a visit, get all this information, hear about getting
Right.
injections in your eye, and the doctor just doesn't have that much time to sit down with you one on one and talk about these things.
Yeah. So the last thing I wanna pose to you, Jessica, before I'll ask whatever closing thoughts you have to share with the audience, is one of the things that goes through my mind when I'm talking to a patient about what's probably foreign to them and scary. And I'm trying to use words that emphasize the urgency of attending to the referral that I'm making, and if I got it right and there is a treatment, that there's going to be some necessity to keep attending to follow up visits and potentially in perpetuity to have the best chance of outcome. While the other part of my brain is thinking, I don't want to scare the patient and push them into a corner where they're just going to stop listening, try to take the approach, ignore it, hope it goes away. So I'm trying to say things that are correct, but not lead them into fear. So, is there anything that you can help me with to help me with my conversation with patients to say the right things and not say the wrong things?
So, I mean, this is an extremely difficult situation to manage. And you walk into a room with a patient, maybe it's someone you've known for a while, and that's helpful because you kind of know a bit about that patient and their personality and their life and, just different situations that have affected and shaped them over time. Or maybe you have never seen that person before and you walk in the room and you have to, you have to sort of pivot what you're doing to, as you said, to kind of narrowly walk that balance being between making them understand the importance of the referral or the importance of the treatment without creating an unnecessary fear for the person. My best advice, and this is what I tell the students, is if you come at this from a place of truly caring about people,
Mhm.
you're gonna, you're gonna do as best as you can. If you truly care about someone and you're trying to balance that, I think that shows. I think patients truly perceive that and they understand that. And maybe you say everything perfect or maybe you don't, but they will get a sense that this is someone who cares about me and they're concerned about me. And the other thing I'll say about that is you're probably going to fail sometimes and that's okay too. I had a patient recently that I think I saw about 3 years ago, and she had some pre-GA lesions. She didn't have GA, and treatments weren't available at the time, so I told her to come back in 6 months.
Mhm.
And she didn't come back for several years, and she came in with some very significant GA, and I went through, what it is, its natural progression, the treatment options. And I got a call from her referring doctor that she had come back to him. She was in tears. She'd had to go to her primary care doctor and get on anti-anxiety medicine. She couldn't sleep at night for fear of going blind. So, I missed the mark there. I let this lady into that state of fear. But you do the best you can and you do what you feel is best for the patient. And when she came back, and I'm so thankful. Another thing about that story is I'm so thankful for the referring doctor to call me and tell me that, and not being afraid to say, like, "Hey, guess what? You scared this lady to death." Because I need to know that for the next time that I see her so that I can pull it back a little bit.
Right.
Well, because as you said, my fear on the first visit is if she doesn't take this seriously enough. I hadn't seen her in 3 years. I don't know where she's been. Obviously, she didn't follow my first instruction. We need to emphasize the importance of doing this or managing it. But I went too far. So now we can kind of pull that back, and you may have to tailor that and just have some really open conversations with patients. I apologize for how the visit went last time. How are you feeling today? Do you have any other questions? And again, the people, I do get a sense, well, I do think get a sense if you truly care about them. And even if it's not always perfect and everything doesn't just go as smooth as possible, that's okay. We're all trying to achieve the same goals.
Perfect. Great sage advice as always. It's definitely something that I'm going to remember. And I've already feel a little bit more confident about this disease state just after our short conversation, Jessica. You've been a great guest. I'm certain that we will talk again. And thanks everybody for attending to this podcast, also on Izervay. Have a great night, Jessica.
Thank you, Chris.
Class is ended for today, and we have no exams or grades approaching. Please email me at foureyeedprofessor@gmail.com if there are topics that you would like to hear and see through a professor's eyes.